My name is Mary Buffington. I'm an assistant professor of clinical medicine in the nephrology department. And I wanted to talk today on left innominate vein stenosis. And I will alternatively call it left innominate, left brachiocephalic. It's the left brachiocephalic, left innominate vein. And so looking at the anatomy, you have the blood draining from the head and the extremities, from the subclavian and the IJs. And on the right, there's a very short right innominate vein. On the left, there's a longer innominate vein here. So it's not symmetrical. It's a little asymmetrical. And you also have the aorta here. This is the brachiocephalic artery. And so this is going to, the aorta may move this, the aorta and the arteries are high pressure. They can push the veins. And then right in front of here, you have the manubrium and the sternoclavicular joint. So it's an interesting area here that causes stenosis, okay? That's anatomically interesting. Looking here, this is showing the subclavian innominate vein, and it drains down and forms the SVC. The two innominates form the SVC. Okay? So that's what you're seeing here, but this is the aorta, and you can see how this left innominate vein really has to take a turn around that aorta and around this brachiocephalic artery. So there, it's dynamic. Here is the manubrium right here. So you have a little kind of these mechanical factors going on there. This is showing a dialysis catheter in the left innominate vein. And you can see how it is just, it's curved, it's torqued around this vessel. So this vessel, the artery is very stiff and it's pushing, and the vein sort of is wrapping around it. So the etiology of stenosis can be injury to a vessel. You can have inflammation. You can have a catheter that's causing some trauma. It's a foreign body in there, and as the heart is beating and as we're breathing, you're going to have movement, and that catheter is going to be moving within the veins. And that injury can be aggravated by all the turns that it takes. Okay, so it has those curves also. Also, if you have a hemodialysis access on the ipsilateral side, you're going to have an increased blood flow there to the venous side, and that changes the hemodynamics. So you will have an increased blood flow. You may get some turbulent blood flow that will change the endothelium, and you may get more pressure in that vein that could reveal a stenosis that maybe wasn't quite, clinically obvious prior to the access being placed there. Also, for our dialysis patients, the uremic milieu is prone to cause vascular disease. And so that can be part of it. The vessel injury leads to pro-inflammatory mediators. You have a pro-fibrotic process going on, and then you have smooth muscle proliferation and intimal hyperplasia. Also, a cause of the stenosis is the central venous catheters, dialysis catheters, also peripherally inserted catheters that cross the subclavian and go into the innominate can also cause central stenosis. Implantation of pacemakers and defibrillators with transvenous leads can lead to stenosis in the vessel, and also extrinsic compression. So looking at what is the incidence of the central stenosis in our dialysis patients? Well, this is a study that looked at hemodialysis patients who just had venography, okay? 41% had central stenosis, but only 8% had symptoms of had stenosis with symptoms. So a large percentage of these innominate vein and other central stenoses are present, but they're not clinically significant. They're not causing symptoms. And what we'll see later on is you don't have to angioplasty those if they are not causing clinical symptoms, and a lot of times they do not advance. You know, they do not progress and get worse and worse. Okay, so the prevalence of central venous stenosis is affected by the number of catheters that a patient has had. If someone's been on dialysis a long time and they've had a lot of catheters, they are more likely to have central stenosis. And one study looked at it, and if somebody had a 0 to 1 catheter, their prevalence would be 3.4%. 2 to 3 catheters, 29%, and then 4 or more, 54%. And so that's big. I mean, and a lot of our patients over the years will have a number of catheters, and all of this is working toward setting up a central stenosis for them. Also, length of time affects. Length of time that you've had the catheter affects whether or not it results in stenosis. One study found that a cumulative days with the catheter of 210 days versus 120, the odds ratio of central stenosis was 3.48. So leaving the catheter in longer will definitely predispose to more of a stenosis. And looking at the catheter, you can see just anatomically, if you have a catheter in the right IJ, it's kind of a straight shot all the way down. It's going in the IJ and it's crossing that right brachiocephalic vein, but it's a straight shot SVC to the cavoatrial junction, whereas on the left, you're going in the IJ, in the subclavian, down this left innominate, make that turn into the SVC, so you have so many turns. So the question was, is having a catheter on the left as opposed to the right, is this left side with all the twists and turns and everything, are they more likely to have problems with central stenosis? So there is a study that looked at that. It looked at 403 right-sided catheterizations. They had a right IJ tunnel dialysis catheter, and then on the left they had 77 with those catheters. And what they found was that having the catheter on the left, they're much more predisposed to have to take the catheter out for infection. On the left, it was 20% of the catheters. On the right, it was only 10 to 11%. Okay, so this may play a role in infection. And then also what they found was then they asked themselves, well, if someone's had a catheter before, does that affect whether or not they have a central stenosis after they get an access on that same side? And so what they found was on the right, they've had 26 ipsilateral accesses. 2 had signs of central stenosis, but none of the accesses had to be ligated. There was stenosis, but it wasn't so significant that they had to ligate the accesses. Whereas on the left, they studied 13 accesses on the left, and 4 of those had signs of central stenosis, and it was so severe that they had to be ligated. The access had to be ligated, and these were profoundly diabetic people who just had tremendous vascular disease. So, and this was statistically significant. So they had the symptoms of central vein occlusion, and the right only had 2, the left 4. That's statistically significant. So the left is having more, okay? And it could be the anatomical concerns. Also ligation, that was, the left is more likely to have a ligation, which is a big deal for a dialysis patient. Okay, looking at pacemakers and defibrillators, we talked about catheters. You know, you have the transvenous leads that are going through and usually it's on the left side. Well, there was a review of randomized controlled trials that showed with pacemakers, they found abnormal venography in 23 to 64, and these are small studies, and the percentage varied widely, and their definition of what was a stenosis varied pretty widely. So I think that's why you're having this wide, you know, the difference between this. But 23 to 64 abnormal venography in the pacemaker and occlusion of the vein in 5 to 25%. Okay, and this is because of the pacemaker. And then with ICDs, which tends to have a slightly larger lead than the pacemakers, They had abnormal venography in 18 to 24% and occlusion in 3 to 18%, which is not that different, maybe a little less. And most of the studies had no significant factors at all, and I think they're very reluctant to say these are factors that lead to stenosis with pacemakers and transvenous leads, but there were some factors, and one was previous lead placement. If they had a pacemaker and say had it changed out for an ICD, they were more likely to have a stenosis. Infection before getting the device, if they had a history of venous thrombosis, they were more likely. And then the presence of multiple leads, 2 instead of 1. Okay? This is an interesting case, interesting study. They looked at 131 patients. They did angiography before they put the pacer in. And it showed that even though they'd never had a catheter or anything in there before, 13.7% had luminal narrowing up to 60%, and completely asymptomatic. This is just a finding that they made for this study. And then they came back post-implantation. They looked at 79 patients they had access to. And after having the leads in there, the percentage went from 13.7 to 32.9. So having these leads does increase the amount of stenosis in the central veins. And so this is showing you the transvenous leads going into the right atrium, right ventricle, but they have they have epicardial leads now, and it's a surgical process, and it's just the leads are surgically attached to the heart, not going through the blood vessels. And so the thinking is that could be something, a good thing for people with chronic kidney disease, because it wouldn't, have this lead going through this vessel for years, years and years, as long as they had the pacemaker. So what they found was it was similar in terms of improving heart function, but they did have a little bit, like 2.5% more pericardial bleeding that was statistically significant. And for one person, that's a bad problem to have, to have pericardial bleeding from that. So it might be a trade-off, yeah. So looking at external compression, you can have aortic ectasia, where you just have a dilated aorta, and then also this brachiocephalic artery coming in there, and it'll impinge on that vein. And this guy did a retrospective review of 48 cases, just looking at this vein here, and he found that 21 out of 48 had extrinsic compression. 25% mild, 13 moderate, 6% severe. So, and he noted collateral veins, and quite a few. So it's compression with collateral veins. So if you have a collateral vein, that's a fairly significant stenosis there. So, this is a real kind of entity here, and you have to think about that if you're going to put a stent. If it's not the vein being floppy and elastic, if it's compression, that's a different sort of thing. This is looking at angiography, the left IJ, left subclavian, and you see the left innominate here with the stenosis. That's a bad stenosis. You have flow going through here, and also collaterals. So you have stenosis with collaterals. They plastied and put a stent, and it looks much better, and you don't see the collaterals anymore. So that's a huge success. But 2 months later, she came back with the same symptoms. And what they looked, I don't know if you can see it, but they did kind of an oblique, fluoroscopy, and the stent looked completely crushed to them. And so they did a CT, and sure enough, here's a manubrium, here's the aorta. Look, the stent is just crushed. So a stent is, you're not going to fix that with the stent. It's a different sort of lesion that you're dealing with there. Also regarding external compression, you can have it in the subclavian. Essentially here in the costoclavicular junction, you have the subclavius muscle, the costoclavicular ligament, and then you have this, the anterior scalene muscle. If someone's like a weightlifter, they can have hypertrophied muscles that can impinge here. And so, the treatment is, if it's their last access or something, you have to remove the clavicle or the first rib, to open that up. So that's definitely kind of a last resort to undergo that kind of surgery. So clinical manifestations, so often it's completely asymptomatic. So they have stenosis, 40%, maybe even 50%. No symptoms, you don't have to do anything about that, okay? Now, what you worry about is when the central occlusion is causing symptoms like arm swelling, they can get shoulder swelling, they can get collateral vessels develop on their chest, and SVC syndrome. Here you see a dialysis patient, access on the left, and then you see this arm looks fairly normal, and just in contrast, you see a tremendous amount of edema, and that builds up because of central stenosis. Okay? It has to be more proximal than the cephalic arch. It has to be subclavian or more proximal. Here's another person, stenosis on the right, and so it's just an obviously edematous arm in stark contrast to the other side. These are vessels, the collateral vessels that develop. So you have a central stenosis, the blood is still going to try to flow, and it can't find a way, and they develop collateral vessels, and you can see this on our dialysis patients. You can see it on their neck and on their chest. They may have a functioning access, but if they have this, that means that they have a central stenosis, or at one time had a central stenosis. And if they're not having arm swelling, if the access is working fine, you don't have to do anything about it, but you just, that's just what develops. This is a person who, when he lays down, he develops face swelling from an SVC syndrome. He has a SVC stenosis. So when he wakes up and walks around, gravity takes effect, and he's able to drain a little bit, and he looks more normal. But there are people living with these stenoses quite a lot. So what do we do? What if we have a symptomatic lesion? How do we address it? Okay. Well, you can angioplasty, or you can put a stent. And so they've done, they have a lot of studies looking at looking at angioplasty, looking at stent, but there are a few studies that compare doing angioplasty to putting a stent. Okay, you're comparing two different things to each other. And so this study by AJR looked at central vein stenosis, comparing angioplasty to stenting. And what they found was that with angioplasty, there were a fewer number of procedures that had to be done to keep the access patent, and a longer primary patency time, okay? So a longer time when the access is open without having to go back in there and do angioplasty to keep it open. Now, this was a retrospective study, but it was kind of large. And then they looked at the average number of interventions. For the stent was 2.7, for angioplasty 1.5. So they were having to do a lot more procedures even after they put the stent in, just to keep it open, okay? So that's not a benefit, according to this study. Primary patency of stent versus angioplasty. For the stent, 13.4 months versus 24.5 for the angioplasty. So there's not a benefit in terms of patency. So, you would not just rush in to put a stent because you're not seeing a benefit here. In this case, they looked at, it was prospective, they followed 44 people for 14 to 60 months, and essentially they found no significant difference in the patency of the stent versus angioplasty. And repeat interventions for angioplasty, 58%, for stent, a whopping 93%. So it's more expensive to put a stent, and it doesn't stay open as long. So And then continuing to look at this study, retrospective query, and what it found was that stent placement does not improve patency of the fistula compared to angioplasty alone. There were 49, and they found kind of an even distribution of stenosis here, subclavian 48, brachiocephalic 48, SVC 4%. Primary patency at 12 months, with angioplasty 29, stent 21, that's comparable. Assisted patency at 12 months, angioplasty 73, stent 46. So it's just not staying open, okay? And then this is a study, this is a really interesting study from 2006, retrospective review of 86 lesions in 35 patients. It was asymptomatic, 24 out of 86 people had asymptomatic lesions. They were not treated and none progressed to symptomatic status, so you don't have to rush in and open these lesions if they are not having clinical symptoms, okay? After these lesions in 62 out of 86 were plastied, 8% of them developed stenosis and symptoms of central stenosis. So if you're not having clinical symptoms, you don't have to plastic. So bottom line, angioplasty, if the stenosis is more than 50% and you have a clinically significant stenosis with clinical signs of central obstruction, okay? A stent is indicated if you have acute elastic recoil more than 50% following angioplasty, or recurrent stenosis within 3 months after angioplasty, okay? Stenting does not improve long-term central vein patency, should not be used as the first thing you do. You can angioplasty and get better results, and it's a lot cheaper, and you reserve stenting in the central only to lesions that are resistant to angioplasty. So in conclusion, the goals of our treatment are to preserve that vascular access for dialysis. We want to relieve symptoms of venous obstruction also. And so we want to avoid central catheters and PICCs in patients with CKD. With regard to dialysis catheters, it's better to have a right IJ rather than a left IJ and avoid subclavian cannulation and avoid PICCs. Cardiac implantable devices use a contralateral arm for dialysis access because you're likely to have a stenosis on the left. So try the right. And then hopefully, people will more and more be using epicardial leads rather than transvenous leads to preserve that left-sided central vasculature for dialysis access. So that's it. Thank you.
I have one comment and one question. The comment is on the pacemaker leads. When I last talked to Dr. Dominic, he said now they have pacemakers without leads, like electronic pacemakers, but they don't have dual chamber pacemakers. So with single chamber, they don't even need the lead. So the pacemaker is just, yeah, you just you put the it's like putting the tip of the lead in the heart. Yeah, the electrode, and then you have a remote. Yeah, it's remotely. That's good.
Wonderful.
So that would get around this, unless it's dual chamber where you have an ICD device. My question is that you presented stents, but were these all bare metal stents?
They were all bare metal stents.
Because bare metal stents literature shows that there is not much of a difference. However, stent grafts, there's literature on stent grafts.
There's one case on stent grafts that looked at 30 people, and what they found was a primary patency at 12 months was 67. 67%, assisted patency 80%, which is good, but you're not comparing it, and you get so many outliers. There's only that one.
The stent graft, although I don't think there are any randomized control trials, but and they compared stent grafts to stents to angioplasty. Stent grafts seem to do.
I didn't see anything where they compared the stent graft to angioplasty.
I recently reviewed, and there was one paper, but they had small numbers. They had 25, 25, 25 in each group.
Okay.
And the stent graft, performed better than the
I want to congratulate you for an excellent presentation. This is a problem that is chronic, existing, and it's going to be here for a long time. I want to ask you some technical questions, and I understand your comment on the stent graft and stent graft. And of course, as you know, what happened with dialysis, with the work of C. Pascal that came out in the New England Journal about the benefits of stent graft for dialysis.
But that was specifically for grafts.
Graft. Yeah.
This is for stenosis.
Yeah, I understand. But what I would say, just technical questions, because we have a lot of residents that are finishing and they want to go outside. So, how do you select the diameter of your balloon for angioplasty, and how do you do it? How much atmosphere you extend? Can you talk a little bit about just a little
Yes.
bread and butter stuff? But I want to please.
Well, central vessels are pretty large. Even if it's a very narrow stenosis, I would probably start with a 10 balloon. I would not go much smaller than that. And you can go, it depends. You have to look at the diameter of the vessel on either side of the stenosis, and that can kind of be your guide. Typically, you can open a 12 balloon if you need to. Essentially, if you open a 10 and then you continue to have a stenosis, you can increase. And our next size is a 12. You can increase that. What you're looking for is not to have, you don't want to have a 50% residual stenosis there. Okay.
So how many atmosphere do you
It depends on the balloon, but the balloon will have a burst pressure. I typically would use a high pressure when I'm doing a fistulogram. I'll use my balloon that I'm using in the fistula, and I'll go to the central and I'll open it there. And that's a smaller balloon. Usually it's an 8 or a 10. So you can open the balloon you have and see the result that you get. And then from that point, you can increase. And essentially, I'm looking for results in terms of just having very little residual stenosis there.
How long do you leave the balloon inflated?
We do at least 60 seconds.
Okay, I'm asking you this question because it's many
So
times.
the general rule is, for an artery, you don't want to oversize the balloon.
Exactly.
For an artery, you want to be the same size as the balloon. It's a venous stretch balloon. You can go 10 to 20% above the size of the adjacent vein. So if your adjacent vein is 7 millimeters, you can go up to 8
In the vein.
in the vein and see.
And how about the diameter of the stent? Because this is an issue. If you put a stent, the stent.
Well, you have to oversize the stent. You must oversize the stent.
I want to point those
The
issues.
big danger of the stent in a vascular access is it's like a tributary of the river. The veins are joining together to become larger and larger, right? So it's like the Ganges or the Mississippi. If you put it in Ohio, once it's landed in Louisiana, it's going to the ocean. No way. So that's the big risk of the stent in the vascular. And second is vascular access blood flow is 500 to 1,500, So it's really high flow. So that's pushing it. And plus you have veins that are becoming large.
This, although technically seems easy, these considerations about diameter of balloons and stents are tremendously important because they can help life-threatening complications.
Yeah.
So, and you can use your balloon size to decide what size stent you want. For example, if you open with a 10, you would probably want a stent larger than that, especially if you have a residual stenosis there. So I would find a balloon size that I liked. I would go up to maybe the 12. If I got a fairly good result with that, then I would not stent. But if it was elastic and seemed to close back down, I would want at least a 12, maybe larger. What size stent would you choose in that circumstance? If you open the central, say you open the vein with a 12 balloon, you go with the 14? Yeah. Yeah, because once it floats, once that stent floats, it's a nightmare. You can jail all kinds of vessels, and you can see once you get out of the brachiocephalic, if it floats forward into the SVC, then you're jailing that right brachiocephalic and the right IJ. You're jailing all of that. It's not going to have that outflow anymore.
And you're deploying the system also. The systems there where they have the thread, the wire, they just open like this. But the catheter-based system where you're pulling, on the metal, yes, the stent opens at one end, yes, and it tends to jump forward. Yeah. And that's very unpredictable what it's going to do. So sometimes better to use a little longer stent.
Yes, and
so
that's
the worst thing would be you miss the zone. The stent has gone beyond the area. The area of your stenosis is a little bit stiffer. It's like squeezing toothpaste out, just so that's the other thing about the stent. Now, as far as the pressure, most lesions open between 15 and 20. But they have now balloons that go up to 40 ATMs. And those are called high pressure balloons. If you can't open between up to 20, then you have to go to that. Balloon rupture is more risky. Or you can use a cutting balloon. It's just little blades that slice the stenosis.
This is what the break nephrology. That's good.
No, the thing is, if you are in the arm, you can control because you can occlude the access. Worst comes to worst, you have clogged it. Central is a little bit risky because there's not much you can do, There's venous blood coming from both sides.
Yeah.
So if you're
This is it's a very important issue, an issue that you see all the time. That's why, in fact, you see, I saw Bigland there, but Bigland, we have worked with Bigland and done, it was a very short study, that we would look into the peripheral vessels and say, the Biglands in general are very much well tolerated, and I think that in view of the central line, sometimes they put a central line for hydration and everything. I think Biglands is a great substitute.
Except for CKD patients.
Oh, is it?
Because for us, the vein is so precious to make access.
Yes. But
so the big lines destroy all these veins.
Destroy the veins?
Yeah.
Not only.
Central are preferred
Yeah.
in CKD patients, chronic kidney failure patients.
Yes.
We try to preserve all these accesses as far the peripheral veins as far as possible.
Is that right?
Yeah. So the recommendation is, if you want to start IV, preferably on the dorsum of the hand.
Yes.
Try to avoid PICC lines in those patients. And if you have to go with a small central like a Hickman,
Yes.
in this subset of patients. But in other patients, it doesn't matter. It doesn't matter.
So you not only do you have the central stenosis from the PICC, because it crosses the subclavian and goes into the, into the central, into the SVC, you have peripheral. So we can't, if you have it in the basilic vein, it's going to be such a big catheter in that basilic vein, it'll be gone. It'll be a string. They'll never be able to make a fistula. Some people will put it in the brachial vein, but our surgeons are able to use the brachial vein for a fistula. So, really it's better. What we do is we put in a Broviac, and we will put in they call us, the PIC team calls us. This patient has a creatinine of 1.5, but it was an acute kidney injury, it was worse, now it's better. Can we put a PIC line? And what we usually say is, let us just put a Broviac, because it goes into the IJ, it's tunneled, it's a single lumen, very small catheter, and it has that nice straight course in that right, so just a straight down, and you're much less likely. Once you cross that subclavian with that PIC line, you know, studies have shown that it just closes down. The subclavian closes down, and once you lose subclavian, you've lost that arm for an access.
Talking about fistulas, how about percutaneous fistula creation? You know, there are several articles on.
Yeah.
What are your opinion on that? You know, there are several articles on doing the fistula
Using
without.
magnets, using infrared rays to punch a hole. Where you go into the heart and you go into the vein. Or you just go into the vein and punch. So those fistulas, when they turn out to be good fistula, they have different configurations, you know.
Because there is recent articles of that, you know, to do the AV fistula is much better than
and the reason that they are good is because they are not touching the vein. They are not moving the vein. When you dissect and move the vein gets injured. So that is not seen with this